A majority of patients on dialysis, or significantly more patients on dialysis, are African American than the general population in the United States. So is that something that we need to be focusing on more? And does that mean that it is that health disparities and people that want to address health disparities would be interested in nephrology as a career?
From my perspective, yes. I think there are many aspects of health disparities, and nephrology is one of those disciplines where, as you mentioned, we see a disproportionately high number of people of color ending up on dialysis or in need of transplantation. And what's really interesting from my perspective is our opportunity as a discipline to really try to uncover the reasons why. And so we have a lot of individuals who are ending up on dialysis, usually because of diabetes, high blood pressure, and then there's combinations of cultural, environmental, genetic contributions. And so from an academic perspective, it's very intriguing on how all of these may come together. And then yet just at a more personal level, the opportunity to make significant improvements to the health of our communities and our loved ones, that opportunity sort of dovetails with the academic piece. So for me, I find it fascinating. For someone who's interested in health disparities, nephrology, I see as one of the more exciting fields to be able to do that work. And so I see that as a great opportunity for people who are interested in disparities work.
Keith, I agree 100%. Sharon, if you want to talk about healthcare disparities, the chronic kidney disease population is the population that best exemplifies that. Overrepresentation of African Americans, overrepresentation of Native Americans, overrepresentation of Hispanic Americans. So if you're talking about healthcare disparities, that's the population that one would want to care for and to study. And we've not talked about research, but all four of us are engaged in research, and the joys of adding research to your nephrology career is something that we could spend a lot more time talking about. But we don't understand all of the health disparities. But unfortunately, not only are there health disparities, but there are also disparities in the health care provided to underrepresented minorities in the population. And clearly, those of us who are committed to improving that care feel a particular mission to take care of these patients with chronic kidney disease, as I mentioned, who are disproportionately represented by underrepresented minorities, and those who are committed to helping resolve these healthcare disparities. There is no better population of patients to pick to improve the care delivered to and to investigate the reasons for health and healthcare disparities.
I agree with that entirely, but I would point out that the disparities relate not just to African Americans, but basically to all non-Caucasian populations in this country. End-stage renal disease is far more prevalent in Native Americans, in Hispanic Americans, even in Asian Americans than in Caucasians. And when you think about the changing demographics in this country, it's not the Caucasian population which is growing, it's the other one. So it's really broad, and it does provide tremendous opportunities, first of all, to try and figure out why. There's been some very exciting work just in the past year or so that's starting to uncover perhaps some of the genetic determinants that might predispose African Americans to be more likely to get focal sclerosis and then go on to end-stage renal disease. So if you're interested in that kind of research, there's just tremendous stuff going on. But also we need to learn more about how the optimal care of these patients. A very interesting study published not long ago in the New England Journal of Medicine looked at, it was a follow-up to the ASK trial, which was a very large prospective trial of African Americans with chronic kidney disease, and it was asking the question, would very tight, aggressive blood pressure control, which we all believe is important, would it make a difference and slow the progression of kidney disease? And it didn't. And that was surprising in some ways. It obviously doesn't mean you don't treat blood pressure, but it may mean that, pushing to a very, very low blood pressure goal in this patient population won't make any difference. And we desperately need more good clinical research in some of it in these specific populations to tell us whether something that we think is true isn't. And medicine is just rife with things that are, sort of common sense and everybody knows. And, these sort of, epidemiologic studies suggest that lower blood pressure is better. Therefore, we should push the blood pressure down on everybody, and maybe it's not true. So there's tremendous opportunities there, but really tremendous challenges. I think we're just, we're just beginning to start to figure out some of these things. But, in the meantime, we've got all these patients out there and more every day. So there's a lot to do.
And one of the challenges is the early diagnosis of kidney disease, and particularly in patient populations that may not regularly seek health care. So we have a lot of room to go in preventive care, as well as taking care of patients once they've actually been diagnosed or they progress on to dialysis. And again, this is a primary care type of role of nephrologists. And so there's just room for lots of different things.
Sharon, you had asked earlier about things that we would change. I know one of the things that all of us face, but I'll talk about my own story in terms of trying to provide the resources to our patients who need care that we know works.
Right.
I mean, there are many kidney protective therapies that we know that are of relatively modest cost, but if you have no money and no insurance and no support from your local community to help support those interventions, then you don't get them. And that's quite frustrating for many of us who know that these things work. We're dealing with patients who are at high risk of getting end-stage kidney disease, yet some of our patients are just not able to get them because of the circumstances that they find themselves in. So that's something else that's another challenge that people who are interested in improving the disparities between different groups within the United States. That's an opportunity for policymakers to help in improving, and physicians have to be in the lead. We're not necessarily going to make the policy ourselves, but we are just a group of professionals that can help advocate for that.